Good afternoon, everyone. We are back with our final session of day 2 of our symposium, and we will be ending today with Dr. Beth Sanford. Dr. Sanford completed her DNP in Public Health and Policy, focusing on vitamin D, and a postgraduate certificate in Applied Clinical Nutrition. Beth is the president-elect of the NDNA and enjoys serving vulnerable populations at home and abroad. So let's give Beth a welcome.
Hi, everyone. Thank you for having me today. All right.
You are good to share your slides, Beth, and we can hear you. So
Okay,
take it
great.
away.
Great. So I wanted to give you all an update on the North Dakota Vitamin D Action Project that we've been doing for the last, well, this is already almost the third year that we've been working on this project. We took our first samples in 2021. We did some in 22. We did some in 23. And now we're just starting with our batch from 2024. This presentation I'm going to give you today is up to the 2023 data. And after I had decided to do this presentation for you, I actually got another grant for another 30 tests. So we will be adding 30 more childbearing age women onto this data, and that should be completed, I'm thinking, by May, and then that will be worked into the paper that the team is writing on this. So I'm really excited about that. You all know if you do grant writing, sometimes it's hit or miss on what you can get, but we were pretty excited to get another 3 kits sponsored. Right, so I don't know if you've all heard my story before, but my inspiration to really do vitamin D research as part of my doctoral work that really led me down even more roads with vitamin D is my daughter. My daughter was really not doing well when she was a junior in high school at the beginning of the year, and she'd always been an athlete involved in fall swimming. And that year she had decided to do cross country. And all of a sudden, about halfway through the season, just really barely could run anymore, would get so exhausted, so sick, would come home and sleep for hours and hours and hours. And her health really degraded throughout the fall. And she ended up having a lot of issues with her menstrual cycle, ended up having a lot of emotional health issues that had never been a concern for her before. And one of my friends, who is a really fantastic nurse practitioner, suggested we check her vitamin D level, and it was 8. And so that kind of began the journey of us trying to understand her health, why her level was 8. It turns out that she had kind of a stealth pathogen. She had active Lyme's disease. And so it was sucking up all of her vitamin D. And so by being able to treat that and get her vitamin D levels up to a robust level again, she regained her health. But that was part of our story of how I got going on this. So the recently published data that really inspired this, hang on a second, let me move myself out of the picture here so I can read my own slides. I don't know if any of you saw that March of Dimes data where they published by state what the risk factor was for preterm birth, but North Dakota scored a C minus. And you know what? I don't know if you guys are like me, but I don't like to get a C. And so I saw that and I thought, ooh, like we can do better, North Dakota. And so that was some of the inspiration for us to look at getting more childbearing age women in our North Dakota project so we could pull out some data and do a comparison on what that might look like. And then also another report, the same report noted that North Dakota had a higher maternal mortality rate than the rest of the nation. Now it isn't much higher. I mean, 24.2 versus 23.5 per 100,000, but any one maternal death is too much. And so how can we look at getting the low hanging fruit to reduce these numbers? And then in addition, in 2021, we had over 2,100 births in North Dakota that were funded by the state Medicaid system, which puts that significant financial burden on taxpayers if there are potentially any complications. And so we are looking at what are interventions that can improve the outcomes for our moms and babies, and also decrease the overall cost to the taxpayer when we're talking about 22% of births in North Dakota. So vitamin D, of course, is very multifaceted, covers so many areas in the body. I just wanted to do a quick recap. Of course, it's talked about as being a hormone, but it's also a vitamin, a nutrient, and a cell signaling molecule. I think probably the cell signaling molecule part is the one that I hear most people say, oh, really, that they hadn't heard of before. And that means it's actually part of that, how the cells communicate with each other, which I think is so fascinating, because that it means it's actually part of the electrical circuit, of the body. And so that's so fascinating to me, how that energy moves and how vitamin D is involved in that energy movement throughout the body. One of the things related to maternal health that's so important is how it actually can upregulate or downregulate genes. So that if something needs to be activated, it can activate it, or if it needs to downregulate it so that the gene isn't triggered, it can do that too. But that's also dependent on what the vitamin D serum level is in the body. And research has shown, of course, that higher amounts of vitamin D, so talking, in that 30 nanogram or 40 nanogram range versus the 20 or lower, you have exponentially amount of genes regulated that can actually help to have happier, healthier outcomes for patients. One of the other things I think that's important for maternal health is the role of vitamin D in the epithelial lining inside of the arteries. So inside any of the blood vessels, that it helps that to be stabilized. Of course, one of the common causes of maternal mortality would be hemorrhage. And so knowing that vitamin D helps with that stabilization of the epithelial lining is really important. And I think it's important for us to talk about that pathophysiology. Otherwise, we don't really understand how vitamin D benefits the specific body system that we're talking about for the patient. I don't know if any of you have ever jumped on GrassrootsHealth nutrient research website, but they are an organization I worked with through my doctoral work. And I gave them ideas on how to design a lot of educational materials for healthcare professionals. And this is one of them, where they already had this document where vitamin D affects every part of the body. But if you look on their website, it's actually hyperlinked. So it will take you to the research in these areas, which I think is really beneficial, especially for we healthcare professionals, to help us better understand the pathophysiology and what the research is currently saying about how it impacts a body system that might work with more in our practice. So for example, if you are working, in cardiac health, you might want to, jump in and look at the circulatory research there that's linked. If you find this interactive PDF. So really, a key concept here is that there's exponential changes that happen to the body during pregnancy, which we all know. And an increase in vitamin D metabolism is one of the really pivotal things that happens. And I tell you what, I'm always amazed when I read research. I'm such a book nerd, but I was so excited to understand really what the importance of vitamin D is in pregnancy. And so in the early part of pregnancy, 25-OHD levels just shoot up during pregnancy. So this is in the first trimester. And so actually, if you don't have enough vitamin D in the first trimester, you will have a miscarriage. It really increases risk of miscarriage. Or you can have poor placental development, that you can have a placenta that won't carry the pregnancy to term. So it can actually even increase later miscarriage or preterm birth because you don't have a robustly developed placenta. And so that's really important. The circulating levels of vitamin D are so high in the hormonal form at this time period that it would actually be toxic and potentially kill anyone else other than a pregnant woman. And so it's so fascinating that the body just really skyrockets those vitamin D levels during that pivotal part of the of fetal formation and the formation of the placenta. This is the only time in the lifespan of a person where vitamin D is independent of the calcium system and it's not controlled by parathyroid hormone. And they call it uncoupling. And this is the only, like I said, it's the only time in the lifespan that this happens. So it's completely independent and it directly acts on, like I said, acts on the placenta, placental development, and of course, fetal development, which was so important when we're talking about those genetic regulation mechanisms. So what the research shows over and over and over is that there's a specific need for serum levels of vitamin D of at least 40. And you can see where this little arc is right here. And it really is, the point where it really starts to level off here is about at 40 nanograms per mil. I think I mentioned this in one of my previous presentations to you, but just in case you haven't heard this, I think it's really important to share is that vitamin D scientists went back and said, okay, let's look at populations where A, sunshine is plentiful, B, where people are really living a traditional lifestyle. And let's see what are blood levels in pregnant women in those populations. And you can see that in this chart on the yellow. And you can see how much higher the average blood level is for a pregnant woman among these East African tribes than males or non-pregnant females. And so that it shows that sunshine is plentiful here. So these people are not out trying to tan themselves, right? They are already in a space where they have to kind of protect themselves from the sun. And this is just their natural vitamin D levels. So when sunlight is plentiful, this is how high the body will naturally raise itself in order to have the most robust pregnancy possible. And so I think it really gives some credibility to what the vitamin D scientists are saying is a great framework, is between that 40 and 60 nanograms per mil. You can even see that some of these women, the Maasai, for example, very traditional lifestyle people, are really almost up in the 70s as their highest range point for their pregnant women. So what happens when you can't get enough vitamin D? So this chart is a good example for those of us who are living in northern climates where we really can only get that robust sun and get vitamin D from the sun at a robust level between, well, robust level is kind of a stretch, but the UV index here in North Dakota goes to above 3 about April 1st, because I clocked it last year, and it goes less than 3 in October 1st. So we have about 6 months where we can generate vitamin D from the sun. Outside of the UV index being 3, we can't generate vitamin D from the sun. And also the time frame of the day when we can generate vitamin D from the sun is only during that midday period. So roughly from 10 or 11 until about 2 or 3 o'clock in the afternoon. So you really have to watch the UV index. Is the UV index above 3? Yes, then I can generate vitamin D. And of course, we know that depends on the color of our skin, right? Because lighter women need less time out in the sun, and women with darker skin tones need more to generate the same amount of vitamin D. So for somebody who's a really light-haired, freckle, redhead, really pale skin, they might need 15 minutes, where a woman who's from African descent might even need up to an hour and a half to generate that same amount of vitamin D. And what this study shows here in this diagram is that in the summer months, of course, the levels went up in the women, but in the groups where their sunlight was not plentiful, it actually went and dipped back down again. And so we can see that if you have sun, the body will hold it high. If we don't have sun, it's going to dip back down again. And I think that just makes sense, but it's kind of nice to see the diagram. And so this slide here is showing about vitamin D deficiency is really a common worldwide issue. And so this is about pregnancy. And you can see that levels that are less than 10 to 12 nanograms per mil are in red, and levels less than 20 are in the orangey color. And you can see really the United Arab Emirates, for example, has a really large vitamin D initiative for women of childbearing age, because really 98% of their women were less than 28 nanograms per mil. Very serious health consequences and risk for maternal morbidity and mortality. And so that's why it's a big public health push in that area of the world. We can also see New Zealand actually has a higher above 80%, lower than 90 nanograms per mil. The US is very low, generally speaking, but one thing I would say is that we don't test as much as other places either. You can see Canada is a little bit higher. Of course, we would expect that because they're at a higher latitude. And we can see that you can see in the USA, it's about 5 levels down there. Among women who are Black or African American, you can see the much higher percentage of women that are less than 20 nanograms per mil, and that's almost 70%. So very, very serious potential for health consequences. And of course, if you're up on your childbearing literature, we know that women of color are more likely to die in childbirth than women who are of Caucasian ancestry. So this is, again, one of those low-hanging fruit that can impact those levels. And so, again, like I said, vitamin D is common among pregnant women. And this shows a chart of a study that was done at the Medical University of South Carolina. And so they've been doing research there for almost 25 years on pregnancy, on prenatal, neonatal outcomes, and outcomes among breastfeeding women. And I think this chart is really telling because it shows in all groups combined, about 31% of people had less than 20 nanograms per mil for their blood levels. And you can see, of course, among the Caucasians, it's lower, it's 11%. But look at, and then it goes up, Hispanic populations, 21%, and then Black or African-American women, 65% under 20 nanograms per mil. And they don't even have the under 10 group pulled out. But I mean, it's atrocious. It's really atrocious. But these vitamin D levels are pretty representative of prenatal vitamin D levels all across the US. So, you know, this study is from 2015 to 2018. And so here we are at 2024, and we really haven't improved much. So I put this slide up there because I just wanted to show kind of the trend in how research moves into practice, right? So, folic acid, of course, we all know is very accepted as being something that we want to take in pregnancy so that women can avoid neural tube defects in their offspring. This took 30 years to move into practice, and it's really the same for vitamin D right now. We've been studying vitamin D in pregnancy since about the year 2000, and it takes 17 years for research to come into practice. We're in 2024 and we are still not moving that robustly into practice. And so some places don't test pregnant women at all. They just tell them to take a supplement. They tell them to take a very low supplement. They tell them to take a prenatal supplement, maybe that only has 800 IUs, or at most one that has 2000 IUs. But it's just a standard dose, and they're not checking those levels in those women to ensure that the women are actually meeting that recommended 40 nanograms per mil. And this is the dose this is the serum concentration that in the research is pivotal to optimize the maternal health outcomes and neonatal outcomes as well, which is not part of this presentation, but will be the next time, because that's what I'm going to be talking about. The next time I start doing presentations is talking about child and adolescent health. And so research has been done showing that doses up to and exceeding 4,400 IUs have no adverse effects on women, and in fact only improve maternal health outcomes. And we can see from the Masai study that levels even up to 70 nanograms per mil are actually normal for women who live in societies where sunlight is plentiful. And so this, again, just goes and shows how we've moved in the trend of research. So the Medical University of South Carolina really made a public health stance. In 2015 and 2016, 2017, they published quite a bit of research showing that there was a decrease in preterm birth when women achieved 40 nanograms per mil. And in fact, in women of color, they had a 78% reduction in preterm birth if they were able to achieve 40 nanograms per mil rather than be lower than that. Average was 60% lower preterm birth risk for women who had achieved 40 nanograms per mil. So this research is out there. It's been published. It's 8 years old. Some of it is over 10 years old. Some of the published research is 15 years old. And so we're really not looking in the research and moving it into practice. And I think we see this when we look at the things for morbidity and mortality. So there's a systematic review that I was part of from a team from Spain that we published back in 2022. And when we were looking through the literature, it was really sad, but interesting to see all the things that correlated to having that increase in morbidity and mortality. So hypertensive disorders such as preeclampsia, preterm birth, which I already mentioned, gestational diabetes, of course, because vitamin D is involved in that insulin regulation, pulmonary embolism, uterine atony. So the uterus can't get tight again after giving birth. It just becomes lazy, right? And then women have a risk for postpartum hemorrhage. Low birth weight in infants, and overall increased risk for maternal mortality. And so that was the systematic reviews, of course, done by that team. And I had the privilege of being involved in one of those reviews. Now, we have had a couple randomized controlled trials, which is when I talk to my friends that are physicians, this is really the thing that they ask about the most is, are there any RCTs? And if you've heard me speak before, I do have a pretty strong stance on that. I really think it's unethical to do an RCT on a pregnant woman because, number one, we know the consequences are very high for the mother and for the infant if vitamin D levels are not robust. Two is if we identify that they are deficient and we don't bring them up to repleted status, then again, we are not providing care. So I'm not a fan of RCTs, but there are two that were done. So I want to share those results with you. So Amiri et al. Just found a 60% reduction in cesarean birth, 93%, whopping 93% reduction in preeclampsia, 96% reduction in preterm birth in levels of 20 nanograms or higher versus women who had severe vitamin D deficiency of less than 10. And they also found significantly higher rates of gestational diabetes, low birth weight, and other pregnancy complications if women had severe vitamin D deficiency. You might think that's pretty severe, but I'll tell you what, when you understand the demands of vitamin D in pregnancy, you can see that women are using whatever reserves that they have, and it's very easy for them to have vitamin D deficiency during pregnancy. Another very recent RCT that was done in the Democratic Republic of Congo found a significant reduction in preeclampsia, preterm birth, low birth weight, C-section, as well as higher APGAR scores and newborn size in the supplemented group. And they only did a once-a-month dose of 60,000 IUs. What I have to say about that, I'm not a super fan of the once a month dosing, and neither are most vitamin D researchers, because what it does is it kind of gives a little false bump in the vitamin D level, and then the body will use the enzymes will degrade it really quickly. And once in a while, you can end up with some rebound low vitamin D. However, it does average out to roughly about 2,000 IUs a day. So it is nice to see that, yes, they found an improvement. And it is a really good RCT to read if you enjoy doing that. And this Amiri study is also good. And then Rastami is another interpretation of these same results from Iran. Very big outcomes that they found from these RCTs. And I think I had mentioned before when I had talked a little bit about maternal health, in a 2017 study with 1,000 women, researchers found that optimizing those vitamin D levels to at least 40 or higher prior to birth versus less than 20 improved preterm birth among white women and non-white women, about 65% among the white women and 68% lower risk among the non-Caucasian women, respectively. That's from McDonald. And the most notable improvement in the study was among non-Caucasian women whose initial vitamin D levels were less than 40, who raised their levels to 40 or higher. Their preterm birth rate was 78% lower than those who did not raise their level. These studies are really phenomenal. I really encourage you to jump in, find these studies and read them if this is what your interest is, because they're just really so significant. And of the non-white women enrolled in this study, 69% were of Black or African-American descent. And so it really gives a good chunk of women that are in that most at-risk population, where they could have risk for morbidity and mortality. Now, I've said this before, and I'm going to say it again. I mean, welcome to North Dakota. Although we did have a really mild winter, everybody's going to go knock on wood now that I heard we're going to have about 8 inches here on Sunday. But we know environmental risk factors pose a huge threat to us here because we cannot generate vitamin D 6 months out of the year. Also, inclement weather drives us indoors. So even if it is April, we may have a huge snowstorm, or we may have temperatures that are, 10, 20, 30 degrees where people are just not outside and active like they are in the lower states. That being said, we have issues with people in Florida and Arizona and that latitude of states as well, because it's too hot. And then people hide from the sun and stay indoors and then lower their vitamin D levels that way. So determinants of health matter. You have to know your own community. When I lived in Asia about 15 years ago, I lived in a really polluted city. And I actually didn't even know until, I suspected, but I didn't know until I started doing vitamin D research and reading articles that pollution actually prevented us from generating vitamin D. And I thought, no wonder all the people that I knew who had moved from the US to live in China, everybody got very depressed after 2 years of living there. And it was probably, I would venture vitamin D deficiency had some impact in that as well. Individual risk factors of course, beyond population health, that we know we have these determinants of health beyond the population of that we know pregnant women are more at risk. Then we get to individual risk factors. So of course, these are things like medication use. I've really been talking more in my lectures about assessing what medications women are on, even childbearing age women, because those medications can leach additional vitamin D from their body. And I know that there are some antidepressant classes that leach vitamin D from the body, and other medications as well, such as the anti-epileptic medications, some steroids. There's kind of a long list. Wakeman has a good article about some of all the drug classes that leach vitamin D from the body, that if you're interested in that topic would be a good article to read. Of course, co-nutrient intake. So that's your all specialty with looking at dietary practices. And of course, we know fast food is a killer, but fast food is so void of co-nutrients that ends up being a problem. People aren't eating foods that have magnesium. People aren't eating foods that have calcium, additional nutrients that we need to adequately absorb and process that vitamin D into a usable format in our body. Body weight. The fluffier you are, the more vitamin D you need to reach that optimal level for you. So body weight matters. So people with a higher BMI are, of course, more at risk for vitamin D deficiency. Occupation. So night workers. I just took the blood level of a night shift worker, and who was having all the symptoms of vitamin D deficiency and was so miserable. And so she was really curious after the education I gave her about what her vitamin D level would be. And we talked about ways that she can improve that level, on her days off, when, of course, when the UVA is above 3. Lifestyle choices. So this is even things that may be what people do for hobbies. Do they have indoor hobbies? Do they have outdoor hobbies? How can we get people outside and actively moving so that when the sun is high, we can teach people on your lunch break, go stand outside for a few minutes, try to get some sun. And a skin color, I already talked about. And then cultural habits, like, are people wearing a head covering? Are people wearing a headscarf? Are people wearing long sleeves so that they're covering all their skin? Or are they wearing makeup that has a UV filter? All the things we don't think about that can actually block us from generating our own vitamin D, which is, of course, would be the best source. And so we need to be thinking about that and talking with our patients about, do they have these lifestyle choices or religious beliefs that may, how they have behaviors that may affect their vitamin D status and give them additional risk. And so of course, for Black and African American women, they're an increased risk for health disparities related to vitamin D deficiency and insufficiency, like I mentioned. And this is because, of course, of that Fitzpatrick skin tone. And we can look across this beautiful picture at all these beautiful women and see their skin tones, but each of them would need a different amount of time in the sun to generate the same amount of vitamin D. So there's some very fair skin populations that can generate 10,000 IUs in about 15 minutes. Well, it would take a darker skin toned individual more like an hour and a half. So it's really individual. And I did forget to put this on the slide, but Australia became the first nation in the world to make sun exposure recommendations based on the Fitzpatrick skin scale and your skin type, versus the previous sun exposure recommendations were all geared toward that very pale, red hair, freckles, very pale skin, Celtic skin. And so very inclusive. And I'm so happy that that Australia went this bold and said, no, this is really about the individual person and what is their skin tone like. And so that is really in a far advance in sun exposure science and making recommendations for the public. So here's the results of some of the preliminary data of our North Dakota Vitamin D Action Project that I wanted to share with you. And so what we did, of course, is we have been gathering data from people all across the lifespan. And just for this presentation and for the upcoming paper we're doing, we pulled out childbearing age women. We have 53 participants that were in that childbearing range. And then, like I said, in May, we'll be adding another 30. So this is what we have so far, is that between the ages of 15 and 49, we had these 53 participants. And you can see from looking at this chart that 94% were below 40, 51% had levels below 20, and 13% were below 10. And so the little green dots is where people had disclosed that they were taking vitamin D. And so we had asked them to disclose. Whether they disclosed or not, we don't know, but we had asked them to disclose. And so you can see that we have a fair amount of people that are below 10 and a fair amount of people that are below 20. Now, this is the one that is really, this chart is the one that's really concerning to me as a healthcare professional and as somebody who is a certified lactation consultant who's worked with pregnant women for many years. Look at of course, we have our Caucasian women. Their levels were 10 to 19 at the lowest group, but look at almost half of them were between 10 and 19 nanograms per mil. And then look at the non-Caucasian women as a whole, 25% were below 10. That's terrible. Okay, there's no way to say this. This is dismal, okay? But 29% of them were still between 10 and 19, and 39% were between that 20 and 29 nanograms per mil. So really below 30 nanograms per mil was literally almost everybody. But this below 10 is really, really bad. Then we pulled out among the non-Caucasian group and pulled out just the women that were Black, identified as Black or African-American descent. 26% below 10 nanograms per mil and 30% from 10 to 19. So that's 56% altogether that were below 20. You guys, I mean, this is terrible. Like I looked at that data and when I first got this chart, I looked at the data and went, oh boy, like we have some work to do in our state. And this really isn't a shocker. There was a couple papers done in South Dakota when South Dakota demographics really started changing about 25 years ago with populations coming from the world refugee crisis, that they had identified that among their refugee population, women levels were really, really low. Norway, Sweden, Finland also have identified that their populations that had crossed latitudes had abysmal vitamin D levels. And here we are in 2024, and we're still have terrible vitamin D levels among our women who are, for the most part, coming in this particular group had come from the New American community in Fargo. Really terrible. I mean, I wish I could hear your voices all go, oh, because you really should be feeling that way. That's how I feel when I see that. When I think about the risk of these women, if they were pregnant, the risks to themselves and their child, it's scary. So what do these mean? I mean, this isn't good. Like I said, North Dakota moms and babies are even more so non-Caucasian women are at increased risk of maternal morbidity and mortality related to vitamin D deficiency and insufficiency. It's just really not good. Okay. I mean, this is low hanging fruit. How do we address this? There's so many things about pregnancy and about the health of people that we have zero input in, but addressing vitamin D levels is really low hanging fruit. You know, supplements are very, very affordable. And if we advocate with our healthcare institutions, they can bring down this outrageous cost of these tests, which actually cost them about $5. They can really bring down that price of that test for pregnant women a little bit lower. I think I've mentioned before, in my hometown area, I nag them so much that they do a birthday lab add-on that you can get a vitamin D test for $15. 15. So our facilities charging $300 is really not, it's really not very community minded. And I'm hoping that with some advocacy, and maybe from this group, we can find some advocates, we can change that. And we can say, hey, how about for pregnant women, we lower the cost of this vitamin D testing and make it more affordable so that they can know what their number is during pregnancy, so that it can be addressed by their provider and themselves to have the best outcomes for moms and babies. And so this really is the summary of my recommendations, is that number one, we need to have some cultural competency education on how to reduce the health disparities between Caucasian and non-Caucasian women related to vitamin D deficiency. We need some higher education initiatives, because we need to be teaching our future healthcare professionals about this issue and how do we be competent to care for our population. We need more continuing education, just like what you guys are doing today, for all of our associations in North Dakota. And we need more community-based initiatives, just engaging the community, especially in these at-risk populations, institutional initiatives in our large facilities, and looking at healthcare policy initiatives across the state level. And so I just want to address these a little bit. And so one of the ways that we can do that is by talking about what are Safe Sun recommendations. How can we support getting that information out to our healthcare professionals so that they can educate their clients, disseminate that information, and really work on helping them to understand what is current evidence-based practice on vitamin D, because we're not doing it. The more I talk about this, the more I hear we are truly not doing it in North Dakota. And how can we move that mark and move the marker faster? And then how do we move forward in higher education initiatives? Of course, I'm over in my corner talking about this all the time. It is really one of my hobbies and favorite conversation topics. But I got a nurse down in Florida who was a student that I was precepting in her doctoral program. She took her own vitamin D level, and she, as a person in Florida, her level was so low that she became really passionate about educating others about vitamin D. And so she's starting to talk and work in her own nurses association to try to get this information out. And then, just through educating nurses, we've got some new American nurses who've caught the vision in the Somali community, the Nigerian community, the Kurdish community, the Liberian community here, and they are sharing the vision with the people from their community. I have a nurse who has been sharing with their own community, family by family by family by family, bringing them a gift of vitamin D supplement and sharing with them what that evidence-based practices, and encouraging them to talk to their doctor about what might that look like for their family. And then one of my students who graduated, who's now working as a labor and delivery nurse in Washington, D.C., that has a very high morbidity and mortality rate for women of African descent. She is my co-author that will be working with me on this paper that we're writing, and is just really blossoming as a nurse researcher and is hoping to go back to school. So and she's such a gifted presenter. Like, I can't wait to go hear one of her presentations someday and hear her fire about vitamin D deficiency in pregnancy. And I have to say, she is the person who really educated me on that African ancestry women die in pregnancy, die of complications and maternal morbidity and mortality more than any other ethnic group in the US. And it was Edwina that taught me that. And I'm forever grateful that she used her voice to share a concern that she had for her community, and that she shared that with me, and it lit a fire under me that this is why I'm really doing this presentation today. So thanks to her for that. Oops, here, I need to figure out how to go back here. So we've also been working in the community in Fargo, working with the New American Wellness Consortium, and then trying to get into some how can we get some community stakeholders and occupational health to be thinking about what are some focused education initiatives that we can do in the workplace, in community centers, places of worship. Because one of the things that I always tell my students is that if I'm laying in the ER and I open one eye, I want to see you and know that you're taking your vitamin D because it's going to help you make the best decisions that you can as a nurse. I don't even want to see you if I know that your vitamin D level is less than 10 and you're supposed to be making good decisions for me. Like, I'm going to be like, oh, find me another one who's taking their vitamin D. Because when you look at all the research on vitamin D and cognition, so I did a presentation on this yesterday, actually, for a group that is working with aging adults. It gives pseudo dementia symptoms if people have low vitamin D. Well, I tell you what, I certainly don't want a nurse taking care of me who has vitamin D levels of less than 20. The research says that they have pseudo dementia, and I really don't want that because they're making decisions that are going to that would be life-changing for me. And so we need to get this education out, even in our hospitals, our long-term care facilities, any of our facilities that we can give to our colleagues who are making decisions that impact the lives of people. We really want them to be up in those robust levels as well. And of course, research initiatives and quality improvement initiatives, I'm just really passionate about. And I think I've talked about this before. We don't have any specific initiatives about this in North Dakota, but really imperative that if any quality improvement initiatives that we are doing standard nutrient design studies that is based on nutrient physiology, where we are looking at that pre and post level vitamin D levels. That we are looking at those serum concentrations and then tracking what are those outcomes for the patient. Because if we are just giving a random dose of vitamin D, 400, 800 IUs, like really a child's dose to an adult, of course it's not going to show that it's effective because we're talking about adults that most of the time weigh over 100 pounds or way more than that. So to give them a dose that you would give it an 8 to 10 pound infant is flat out ridiculous. And that's what some of the studies are designed like. And so we need to make sure that if we're doing quality improvement or doing research, that we are looking at what is the current evidence-based practice and what are we using for markers and metrics. Healthcare policy initiatives, I think, are really important to do that overall from a socio-ecological model, looking at that level of doing a systems-based approach to change. And so Alaska did a health initiative back in 2013 where they passed a concurrent resolution to address vitamin D deficiency from a primary prevention standpoint. This is my dream that North Dakota would also adapt a concurrent resolution like this. I do have a small group of people who are interested in working on some legislation like this for the next legislative session. If you're interested in doing this, please reach out to me, and we need to do some education with our legislators, because if we can pass a resolution like this, it can potentially free up some research dollars to help us do more research in North Dakota to show that there is a need. I mean, just my tiny little project alone has given enough data for me to do all sorts of presentations around the state. My next presentation, like I said, is going to be looking at the child and adolescent levels, which are just as abysmal as these childbearing age women levels. And so it just gives we have the basis to say we have a problem now. So let's find a solution so that we can get this low-hanging fruit of our people being sick and keep people as healthy as they can be. Again, I have shared this many times, but I just want to share again, some of these best practice resources are available for free to you at Grassroots Health Nutrient Research Institute. Some of these I made during my doctoral work because I told those scientists there, we need to make this easy for healthcare professionals because they're busy and they're not going to read 500 vitamin D articles. So we need to condense some of this information. And of course, you can take the CEU course that's available. I do still have a code that if you're from North Dakota, you can take it for free. So I could get that to the academy and they could give that to you. But any of these handouts and resources are free for you to use to educate yourself and your patients. We do have the vitamin D, the quiz, which is a risk assessment quiz that's evidence-based that you can go in and have your patients take this quiz, and it will tell them if they're at medium or high, medium, or low risk for vitamin D deficiency. And then it will email them their own list of risk factors for them to take to their doctor or so that they can justify that they might need to have a blood draw. And so this tool A has already been tested. We designed this in part of my doctoral project. It's been tested, it's evidence-based. That's just another article on the list that we're writing. And we actually have a couple other groups now that are testing the quiz again for additional validity. And so that's really exciting. And it works. Like, you can just go in there and click it and it'll tell you, oh, I'm low, medium, high risk, boom. And it's designed to educate the healthcare practitioner and the patient, so that by the time the practitioner has done a few of these quizzes, you can just ask the questions. And if you know if your person is really at high risk or not. So it was designed to educate each other. The vitamin D calculator, if you've never went around on the website and fooled around with this, it's really amazing. So I'm doing a quality improvement project right now with a hospital where they are using that calculator to calculate the dose of vitamin D for each individual patient after they get that initial serum level. And so they're doing the serum level, they're doing the calculator, they're getting an individualized dose for the patient, targeting 50 nanograms per mil. And then we're tracking patient outcomes. So they're tracking wound healing. They're tracking, oh gosh, I'm just blanking right now. They have a list of metrics that they're tracking, and they've been doing it for 1 year now in March, and we're going to be having more data to analyze and to disseminate, write in a paper and disseminate. And honestly, it's so exciting to me. Their hospital-acquired infections are down. And just their patients are doing incredible, and they're very excited about it. So in conclusion, just our little study implicates that we have a need for public health action for women of childbearing age in our state, with additional emphasis on at-risk populations in the state, such as women that are ethnic minorities, and women in poverty. And I really recommend, and when I went through this data with the group that I meet with, that is working on a national initiative, they really were shocked at how low North Dakota women were, and were very concerned. And one of them is one of the doctors from MUSC who's been working with this for 25 years. And she was very concerned at the levels of our women. And they were suggesting that we do a statewide healthcare initiative, that we do institutional research, quality improvement programs, that we track patient and financial outcomes. Because what speaks to legislators is that we're saving the state money. So if we can show that we're saving Medicaid money, then the legislators are happy. And so this is really important, that we're not only tracking our patient outcomes, but looking at how many days are they in the hospital? How many days do we have maternal morbidity? Hopefully we don't have maternal mortality, that we also start doing more outreach programs in the community. And then institute the prenatal protocols that they have at MUSC, which are that they test 3 times in pregnancy. So they test right in each trimester, and that they test close to birth to make sure that the woman has achieved a serum level of 40 before she gives birth. And so that's really important, again, for that, those improved prenatal outcomes. And then family education as well. So what does that look like? If you have a Muslim or a Jewish family who doesn't want to have the pork gelatin or have any kind of gelatin capsule, what do they need to do? Do they need to do vitamin D drops? So that we have the appropriate intervention for the patient's cultural and religious beliefs is really important. And also the safe sun exposure guidelines. And if we implement these interventions, it is expected to improve those state perinatal outcomes, so that we are not getting a C- anymore. I'd like to move that up to A. I'm kind of an A+ kind of nerd, and I'd really like to see us move that direction, not be hovering down in this C-. I know some of you that are also, school nerds like me are probably just cringing at the thought of us being a C-, but this is really where we're at here. So we need to do something, and a call to public health action is really what's needed for our childbearing age women. And so again, couple things that you could institute right now if you work with pregnant women, is that you could be part of creating a policy and procedure to do this 3-step prenatal testing method to get those levels replete up to 40 for your facility. Be involved in creating a quality improvement project. Now you can do this no matter what area you are in. If you are working in a cancer center, if you're working in cardiac unit, wherever you're working long-term care, you can create your own quality improvement project and use facility specific metrics that matter to you. Just make sure that you use the Haney criteria, which is you're looking at those pre and post vitamin D concentrations, and recommending that you use the vitamin D calculator so you get those individual weight specific guidelines for each patient. Especially also if you're working in mental health, there is a hospital that has published research that they give 10,000 IUs to every adult that enters in their psychiatric hospital doors. And their outcomes are phenomenal for their patients. And this, again, not new, for probably about the last 15 years. So this is not new stuff. It's just things we're not doing here. And it's things that we can do better. And then also one of the things that I really recommend to just increase awareness among all of your staff is to create a staff education and testing event where you can partner with a local lab and you can ask for discounted testing services. One of the things that we found is effective is that the larger hospital systems will offer a discount if you are doing a quality improvement project. For example, we got the cost reduced from, I think they normally charge $300 down to $60 when we said that we were doing a QI project. And so that's really a significant cost savings to your staff and to the patient if we are actively doing a quality improvement project. And then of course, disseminate your findings. If nobody is talking about the research they're doing, it doesn't benefit anyone, right? If I just kept all these results as a secret, how is it going to help any women in North Dakota? It's not going to help anyone, right? And so we need to be disseminating and take the time to write that article for publication. Just do it. Chip away at it, write an hour every day. It'll be great. And then I'm still wondering, is anyone interested in doing a Northern Plains Vitamin D conference? I said this to the people with the aging yesterday. We could do an aging track. We could do a prenatal health track. We could do a mental health track. We could do inpatient outcomes track. I just have all the ideas. So we just need to have people who are passionate about doing it. And what does great look like here on this issue? What does great look like for your facility? If you're not sure, ask. You know what? I'd love to help you. And that's it. That's all I've got for today. I'm just passionate about health for North Dakotans and really want to encourage you to start using your voice and reach out in your practice setting and make a difference where you work and in your own community. Thanks for having me.
All right. Thank you, Beth. There are a few questions here for you in the chat. So I can either read them to you or you can open up the Q&A and answer as you go. Which would you prefer?
Let's see. How far back should I go? I'm scrolling here.
So it'll be in the Q&A box, not the chat.
Oh, the Q&A box.
Yep.
Okay. Actually, so regarding Native populations, some of the 30 new test kits that we got, I'm directing towards some Native women that I know. And so I just got a great partnership with a Native woman who's going to help get me some robust, and I'm hoping to get a presentation specific for Indigenous women maybe in the next 6 months. But that depends on how many of them we can get. But she's excited about it and she's educating her own community. So I have a feeling we're going to be, but I'm hoping if I can get 20, then I think it would be enough to at least start the conversation. Do I think moms should have the vitamin D test before they're pregnant? Really, it's a really good idea to have this conversation at the level. I think that when women are just doing their annual exams so that people know how important it is. Remember, I don't know if any of you, if you're at my presentation before, but when I talked about the breast cancer research, I think it's important for women at every age to understand how vitamin D deficiency makes them more at risk for breast cancer. I mean, if your level is above 60 versus below 20, you have an 80% risk reduction of getting breast cancer. And so I think it's definitely a conversation that we want to start earlier, that we want to be having, before women are even pregnant. Just, during maybe that annual exam, encouraging that at annual exams or in primary care would probably be the best option for that. If anybody's working in Women's Way, I'd really love to get an educational flyer in the Women's Way packets. That's something that we're looking at doing in California. And I'm hoping that we can move that here in North Dakota as well. Okay, what is the best vitamin D education sheet showing the effects on the vitamin D? Grassroots Health has a lot of really good education sheets. I actually just talked to them the other day about making a new one with some of the brand new studies on it, because I think that you're right. I think that we need a one-stop shop flyer for providers so that they understand, oh, this is what we can see. But on Grassroots Health website, they have a lot of things already made. They have like a bar chart. They have they call it a dip chart. They have one for non-pregnancy, and then they have a specific pregnancy dip chart, although it does need to be updated with some of the current science. Cost of testing equipment. I really think that, so I talked to an administrator, gosh, this was during the pandemic, so it's probably 3-4 years ago already. The actual test of the vitamin D test is not expensive. And apparently it doesn't really require any outrageous equipment. Like, it's kind of standard equipment. And so I really wish it was something that we could do at a state level, that the state lab could do it and that they could offer it really inexpensively. But I don't know how that would work. But I just know that in communities around the nation, they've been able to negotiate and get the cost to be much, much lower. I know in Missoula, Montana, it's $35 for any pregnant woman. And like I said, in Watford City with the birthday lab add-on, it's $15. It's so cheap. You can get $40 tests, I know, at some private providers' offices here in Fargo. I know in Bismarck, they have a Labs Your Way there that I think charges between $40 and $50. So I think it just depends. But this is definitely an advocacy issue that I'd really like to have some more conversations about. Okay, the Fargo Watch Party is wondering about the hospital you mentioned. Was it a one-time of providing 10,000 users every day during their stay? So yes, so the psychiatric hospital I mentioned, and this is a paper by McCullough, and it's out of a psychiatric hospital, I believe in Ohio. They give 10,000 units every single day while they're in inpatient, not just a one-time dose. And so that's a pretty standard dose for somebody who's maybe 175 to 180 pounds. And so they just do that standardly, because what they found is that everybody who enters their hospital, if you are admitted to inpatient psych, typically your vitamin D levels are in the toilet. And that's what they found. So they really just started giving everybody across the board this 10,000 IU every day upon admission. And that they do that actually instead of testing everyone, because just from years and years of testing, they found that everybody was so low. And I think I had mentioned in a previous lecture, if you heard last time, that the suicidal ideation range of people coming in when they get tested, they're usually less than 18 nanograms per mil. And so if you're under 20, especially under 15, your risk of having suicidal ideation is much higher, because there was studies done about being in the ER and what your serum concentration was if you had suicidal ideation or an attempt, and it was much, and obviously the average blood level, I think, was like 15 nanograms per mil. Okay, what is being done to get more healthcare providers on board to recommend vitamin D testing? You tell me, other than me, like, I don't know. So like, I don't want to get tired on this, y'all. So come and help me. And also Medicaid has been approached to cover testing for pregnant women. I do not know. I know that like Blue Cross, for example, will cover the test for pregnant women. They have different strata for testing. I'm not sure what medical assistants, what they pay for. Maybe, is there anybody who's a practitioner in a room who's a prescriber? They might have a better idea. But I know it's a big issue. I actually have a friend who's on Medicaid, and half of her hair had fallen out. They did so many tests. I mean, I think they did, like, she said I mean, $1,000 worth of tests, and they didn't find anything significant. And then I gave her 5 articles about vitamin D and hair loss, and she had to go in and really demand that they test her, and her level was like 6 or something pathetic like that, 6 nanograms per mil. And then she said she yelled at her doctor. She's Middle Eastern, and she yelled at her doctor because she was so mad. She said, I've been messing around with this for months and months and months. Half my hair has fallen out, and you didn't even check my vitamin D, and you had done thousands of dollars of testing. And the reason they told her that they wouldn't do it is because it was too expensive, but they had already spent $1,000 or more on other tests. And so I don't really understand what the deal is with that. But it definitely is an issue that needs some more advocacy. Is there a way to find out the locations that have more reasonable costs for vitamin D testing? It really depends on your community. Like I said, I know there's a place in Bismarck, Labs Your Way. In Fargo, I do know some private nurse practitioner offices that they do testing for like $40 to $50. So you can just call around and ask. I would call your local hospital and ask them, and let's start advocating. I mean, can we as professional organizations start advocating for lower costs, at least for an annual, like for one annual birthday lab, can they do a lower price for a vitamin D test? I think that'd be really beneficial. Otherwise, I know that you can get online testing. For example, GrassrootsHealth, that with their research project, they offer vitamin D test kits. When they do a discount, they're like $60 to $65. So that's still pretty reasonable. But you have to snoop around, but you can find more affordable testing. Okay, thank you for all your work and sharing with this. Vitamin D supplements. I think I typically buy mine from Swanson in Fargo. I think really they're pretty good. You know, they're pretty standard. I guess I don't really have a preference. I haven't had any. I know the Swanson ones are cheap, and sometimes you can get them 50% off. So I usually get my vitamin D for $10 a year. It's really 3 cents for 5,000 units when you get them on sale. So it's really pretty affordable for everyone. I know the country of Bangladesh, actually, they have a grassroots movement where they are educating pharmacists and doctors just in local communities, because people that are living in poverty can afford a vitamin D supplement, but they can't afford medical care if they get sick. And so they're trying to affect the health of the people by giving them something that's going to help. So, it's really an affordable cost for vitamin D supplements. I'd really like to see us do some legislation to get vitamin D supplements be reimbursed by insurance. I know that there's some other supplements like weight loss supplements that are reimbursed. So to make it be easy, that it's easier for people to have it be considered a prescription so that they can get that cost covered. But it's really only $10 a year for an adult who's taking 5,000 units a day. So it's not very expensive. Are there any other questions? Sorry, I talk so fast. So actually, there's a really good study that was done at MUSC by, I don't know if it was Dr. Hollis or Dr. Wagner, about breastfeeding women. You need about 6,500 units of vitamin D daily, roughly, to have 400 IU spill over into the milk. And so it does take quite a bit of supplementation to fill the vitamin D tank, right? So what they found in the research is that women have to have their tank be about 50 nanograms per mil in order for it to start spilling over enough for it to get into the breast milk. So I think that's interesting because it kind of shows us where the body would like to be before it'll start sparing for someone else, right? And so for women who are breastfeeding that I know, I always encourage them to get ample sunshine, of course, and do not burn, right? No burning, but we want people to get ample sunshine as much as possible. And if they can get their vitamin D level checked, that's even better, because then they can know if they have a health condition that keeps them in that lower end. Like, for example, if they have GI issues, if they have food allergies, If they're taking other medications that are leaching vitamin D, we really do want to know the vitamin D levels of our breastfeeding women. So that, I mean, it doesn't hurt to supplement the infant, but you can supplement the mom and it'll spill over to the breast milk, if that answers your question. Although up here, I tell you what, I really would love to see moms be better about giving their infants that vitamin D from birth, because, you know, we know that it prevents diabetes type 1. We know about the childhood cancers. I mean, not even to mention other things like looking at ADHD or other things that they're looking at in the research, asthma, things like that. So we really do want to encourage our mothers to be giving their infants done.
All right. Well, thank you, Beth, so much. Clearly there's a lot of interest and in this topic. And again, you were with us last year and brought you back because of the desire to learn more. So Emily did drop in the chat the evaluation link, but I'm going to turn it over to Bree for closing words as we wrap up our symposium for 2024.
Thanks, Katie. Wow, my head is just spinning after that, Beth. Thank you so much. There's definitely enough there to do a full conference, and I think that's a great idea. So thank you for being with us today, and thank you to all of our speakers during the symposium. It's been an incredible couple of days. So big thank you to our speakers, our poster presentations, our expo participants, and of course our sponsors, and a huge thank you to our planning committee. You guys are just amazing. It's really been a great couple of days. Emily dropped in the chat to be looking for information on, she dropped in the chat to please complete the evaluation. We'll also be sending it out via email along with information for getting your CEU certificates. Just one last plug that we've got a webinar coming up in May on artificial intelligence, and we'd love to have lots of attendees for that. So just visit our website to find more details on that. And just keep an eye on your emails. Thank you everyone so much for joining.